Good morning, everyone. Welcome to our first coffee break of the day, and thank you for your interest in diagnostic tests for the investigation of miscarriage. My name is Laurentiu, and I will be your moderator today. I am pleased to introduce the expert, who is Dr. Matt Pryor, a consultant gynecologist and subspecialist in reproductive medicine at Newcastle Fertility Centre in the northeast of England. He is passionate about working together with patients to provide individualized care. Dr. Pryor has coordinated the Miscarriage Priority Setting Partnership that aimed to develop priorities for future research. He was awarded a PhD for research into miscarriage and fertility problems. Before we start, there are a few housekeeping rules that I would like to mention. First, there are two ways to interact with Dr. Pryor. One is by raising your hand, and the other one is by using the Q&A chat box at the bottom of your Zoom screen. Apart from this, I would like you to be honest and truthful when engaging with us. And remember that the views expressed are your own, so you are responsible for what you're saying. Please don't spread any rumors or fake news, and if you suspect information might be false, better not to mention it. I don't expect it to be a heated topic, so I don't expect any personal insults or rude language. And also, please don't use this platform for commercial purposes. Thank you for joining us today. The floor is yours now.
Good. Well, thank you very much for having me, and thank you to everyone sort of joining. Well, it's quite early here in the UK, but I think there's people from all over Europe and the world, so thank you very much for coming. This is very much, and the idea of these coffee break discussions are really kind of discussions, so it's good to have lots of contributions from everybody and questions, really, to perhaps share people's practice from around the world. And I'm just here to kind of act as a guide as to perhaps what some of the evidence is and kind of start the discussion off, really. So thank you very much for the introduction. So I only have one slide, well, two slides actually. So this one here, basically with the title. So we're going to talk about tests that people do for recurrent miscarriage, basically Europe versus the rest of the world versus the guidelines. And it's really interesting, this, as Laurentiu said, when I did my research, the idea was to get research priorities, questions that are important to patients, not just researchers or people who fund the research, but find out what patients want to know. And really high up there in the top 10, what patients wanted to know, look, why do I need to wait for however many pregnancy losses to have tests done for recurrent miscarriage? Why can't I have tests straight away? And I guess that's kind of something that's very important for patients, but we need to then think back kind of the other side of the coin, which is about why do we do tests? Are tests there to guide our management? Are they there to answer questions? What's the purpose of tests? So this is my one slide that we have, which essentially compares all of the different types of tests that you can do for recurrent miscarriage. So I think if I spend a couple of minutes just giving a rough overview, and then let's just sort of get into kind of discussing perhaps each one in a bit more detail, and this is where your kind of questions and things would really help. So first of all, going through the ESHRE guidance for recurrent pregnancy loss, there aren't really that many tests that are kind of recommended, and the main sort of rationale behind it was really there's a few tests you could perhaps do for explanatory purposes. So the most common question that people submitted to my research was, look, why did I have a miscarriage? And I suppose that, as we know, most miscarriages are due to aneuploidy. Then genetic analysis of pregnancy tissue is something that's potentially recommended just to explain to patients perhaps why they had a miscarriage. And that can't be underestimated, really. But then it also suggests perhaps other tests for explanatory purposes might even be DNA sperm fragmentation or anti-nuclear antibodies. Now, these aren't tests that we do routinely in practice. The next thing is then looking at women who've had 2 or more pregnancy losses, and it seems that the world is now kind of focusing more on kind of defining recurrent pregnancy loss as 2 or more losses rather than in some places 3 or more. But the recommendations was thyroid screening, assessment for uterine anatomy, so basically look and see whether there's any uterine anomalies, and antiphospholipid antibodies, and that's it. The only other tests that could be guided were based on if there's a particular medical or family history. And the important thing to notice is that actually basing the prognosis on the number of previous pregnancy losses and female age is really helpful. And the guidelines, although they don't mention it in the very extensive guidelines, as you probably read, but they do reference a paper which I show every single patient who comes to my recurrent miscarriage clinic. It's a paper from 1999 by Brigham. And what that does is it followed up patients based on the number of previous miscarriages and their age, and showed the likelihood of their next pregnancy being successful. And even when you're looking kind of at the extremes of age, so women over 40 with perhaps 4 or 5 previous losses, you're still looking at about a 60% chance that they have a baby with their next cycle, and that's doing nothing. So that's really helpful. So you contrast that with kind of the ESHRE guidelines, and they suggest perhaps doing a few other things, sort of looking for balanced reciprocal translocations, antiphospholipid antibodies, that's the same. Perhaps assessing uterine anatomy, but using different tests, and we can perhaps talk about that soon. And then also looking at prolactin, TSH, and HbA1c. And then other tests kind of that the rest of the world sort of talk about and sometimes do, but recommended not to do according to the ESHRE guidelines, sort of parental karyotyping, thrombophilia screening, different types of antibodies, cytokine testing, all the reproductive immunology, and then assessment of PCOS, metabolic problems, ovarian reserve, and then luteal phase insufficiency, which we might also come back to as well. So I think that's kind of just, and I'm going to leave this slide there whilst we have our discussion, essentially just to sort of guide us around some of the different tests to talk about. I think it might be helpful, depending on what Laurentiu wants to do, to kind of perhaps pick up a few of the tests and have some discussions around that. That kind of is an overview, all the different tests you can do, and then we can have a discussion about that.
That's very good, thank you. Dear participants, now is the time to ask your questions by either raising your hand or writing them in the Q&A box. We already have a question. I can't see the name. It would be useful to also mention the country where you're asking from, just so we can try to map everything. Do you differentiate the decisions to treat slightly raised TSH just above 4 by the presence or absence of antithyroid antibodies?
So that's a really kind of good point, really. And one of my sort of, I suppose, role models / mentors throughout my research was Ari Kumasamy, who has done a lot of research into this area, doing the PROMISE PRISM trial and also the tablet trial. Now, the tablet study looked at patient women with, if you're not familiar with that, it was published maybe last year or year before in the New England Journal of Medicine. And there's been lots of information previously, which sort of weak evidence, which suggested that perhaps recurrent pregnancy loss could be associated with antithyroid antibody, anti-TPO antibodies. And that trial basically randomized patients to having thyroxine or placebo, and it didn't show any difference at all. So I'm a bit sort of skeptical as to whether thyroid antibodies are kind of even associated, or sort of whether treatment can make any difference, and whether this is perhaps a little bit of a red herring. So that's not something that I would do, would treat. If someone's got kind of overt thyroid disease, hypo or hyperthyroidism, absolutely that needs managing. But personally, I'm not so convinced by kind of thyroid antibodies.
Thank you.
Controversial.
Yeah, thank you for your answer. Just another question. This one will be from me, waiting for more questions from the floor. Do you think there is a difference between government-funded clinics where the test would be free and private clinics where the patients would need to pay for the tests?
There is a difference, yeah, but I think kind of raises a much deeper, almost like ethical question in medicine, which is about sort of what's the right thing to do for patients and why do we do tests. And going right back to first principles, the main reason why we do kind of tests or screening in medicine is if there's a treatment available or if it's going to change your management. And I think that kind of should really sort of make clinicians think carefully before they do tests, because often you can get funny results. And I mean, this is kind of I saw a patient yesterday who'd been to see a functional doctor. And for those people who might not know, functional doctors are not medically qualified. They're very common in the United States, and they'll go and do a whole batch of tests, kind of check every kind of antibody, hormone levels, absolutely everything. And it's typical when you do this many tests, a bit like when you do a full blood count, you'll always get something that comes up red that's not normal. And it's very easy to kind of tell the story back to the patient that, look, this is the reason why you're having a miscarriage. This is the reason for your medical problem. Take this mushroom supplement or whatever, and this will kind of put everything back in, restore balance. And that is the narrative behind kind of functional medicine. And I think that as clinicians who are practicing evidence-based medicine, we need to be really cautious about that, because while perhaps and that tends to be more common in private practice, because government-funded hospitals normally have kind of more evidence, more based on the evidence and stick more to guidelines. I think we just need to be really sort of careful about what we offer to patients, and are you actually practicing medicine, or are you just trying to bamboozle patients into some kind of narrative that may not have any evidence behind it? So, I mean, that's kind of raises that bigger question, not just about miscarriage, it's kind of medicine in general, but certainly with fertility and reproductive medicine, recurrent miscarriage, there are a lot of people out there who will readily do other kind of tests. That, having said that, I think the other key thing is actually research is really important. There's still so much unknown about miscarriage, and we keep doing lots of studies looking at treatments for miscarriage, but there's so much kind of unknown about kind of the causes of recurrent pregnancy loss. We look at chromosomes and aneuploidy, but there's still the possibility there's plenty of perhaps lethal recessive genes that haven't been understood yet. So I think there's a lot more research that needs to be done to try and find why miscarriages happen, to then be able to design tests and then hopefully treatments. But they should be very much kind of part of research studies rather than just let's give it a go.
That's very true. Thank you. Just a few short questions with answers now, because we are getting close to an end. Mina is asking about your opinion on using intralipid after testing for genetic testing for thrombophilia.
So I think that for me comes into the category of not really having any good evidence behind it. And the reason why is like if you could show me a highly powered randomized controlled trial which shows that the use of intralipid improves pregnancy outcome, then yes, I would recommend it, but I don't know that. If you look at the Cochrane review, there are no large trials of intralipid. So while perhaps that might fit under kind of the narrative that perhaps intralipid might help with kind of reproductive immunology, it's still very much theory rather than proven. And there are kind of risks of intralipid as well, whether it be anaphylaxis, it's expensive for patients, and is it something that's kind of selling false hope? So I'm not an intralipid fan.
Great. Thank you. Yes, it's all about the evidence. Somebody is asking about the use of prolactin. How would you investigate?
Yeah, it's interesting prolactin. So, so the ASRM recommend checking prolactin levels, and but ESHRE say only to check prolactin if there are any sort of signs of hyperprolactinemia. So I'd very much and I think with all these tests, kind of almost the first chapter of the investigations bit in the ESHRE guidance is take a good medical and family history and tailor your tests around that. So if someone's having kind of prolonged menstrual cycles and they might have a headache, or I mean, they're unlikely to have the bilateral hemianopia, but with the microprolactinoma. But if they've got any symptoms, then absolutely check prolactin. But prolactin's also one of those tests that quite readily comes back a little bit raised. So you like the cutoff, I think, is about 450, and you often might see it kind of 600, 700, 800, and it's also a very sensitive test to if someone's a bit nervous when they're having their bloods taken, you'll get a falsely elevated prolactin level. So unless it's and that's very easily, especially if you're a kind of doctor that does loads of tests and then wants to find someone and go, oh yeah, that's the reason for your miscarriages, you've got a raised prolactin, when it might just be that they were stressed having their bloods taken. It can kind of come back almost a bit like a false positive. So I think really, unless they've got symptoms, I would be wary about doing prolactin. An endocrinologist that I work with is very kind of gave me a good kind of lesson in this, which was if you've got a series of prolactin levels over the last few months, you can always go off the lowest one. If someone's got a prolactinoma, it will get higher and higher and higher. But if you've got a few that are sort of a little bit outside the normal range, you can always go with the lowest one. So it's worth checking if there's symptoms, but it's unlikely to be the explanation for miscarriage.
Thank you. I'll just go straight to the last question now, asked by Anju, who's bringing into the discussion the NK cells. What's your view on those?
Natural killer cells.
Yeah.
So it's really interesting. So Siobhan Quenby in Warwick, part of the UK Centre, Tommy Centre for Miscarriage, does a lot of research into NK cells, and certainly peripheral NK cells I think have nothing to do with miscarriage. Uterine ones, a bit more interesting, and perhaps even Laurentiu might be able to tell us a bit more, because this is part of the topic of his PhD, was looking at kind of genomics of the endometrium. So he's probably more an expert than me on this, but like I say, there's still, when you come back to clinical trials, there's not anything to show that sort of giving steroids or anything like that will improve pregnancy outcome for patients with recurrent pregnancy loss. So I still think that NK cells, while they're interesting and they've got a fancy name, are more helpful in terms of kind of research at the moment rather than clinical practice. What do you think, Laurentiu?
I completely agree. And yeah. So our session is coming to an end now. The time frame is very short. It appears there's still quite some variability in the way that we investigate recurrent miscarriage. And as you mentioned, one of the factors influencing this appears to be who's funding for the tests, with government-funded clinics being more evidence-based and private clinic recommending, a broader panel of tests based on the fact that patients would pay for them, even though they are not very supported by evidence. I hope you enjoyed the rest of the day, and thank you for attending this session. Goodbye.
Good, thank you.